The news from EADO about the neoadjuvant approaches to melanoma. Over the last years, there have been a lot of big developments. There have been studies done for targeted therapies with BRAF/MEK inhibition, followed by surgery, followed by then continued BRAF/MEK inhibition to complete a full year of therapy. Showed very high response rates, but not a lot of durable responses in terms of a lot of these patients eventually do relapse despite still being on or after finishing a year of targeted therapy, as is similarly seen in the large phase 3 adjuvant trial COMBI-AD. So the interest has shifted more towards the neoadjuvant immunotherapy trials, where we had a few trials with single agent immunotherapy. There was one trial which was published by Wang et al., which looked at a single dose of pembrolizumab 3 weeks prior to the surgical resection. And amazingly, they saw a 25% complete response rate after only a single shot of pembrolizumab. Similar has been seen for a study where a monotherapy of nivolumab was used, but higher rates of overall and complete response were seen with the combination of IPI and Nivo. So both a study from MD Anderson and the OPACIN study showed us response rates in the order of 60 to 80%, with many patients getting a complete or a near complete response. Very interestingly, there's an international neoadjuvant melanoma consortium, the INMC, which had a pooled analysis of all these neoadjuvant trials and showed us that the benefit of neoadjuvant immunotherapy seems to be very durable, with 0 people relapsing after achieving a complete response. So in this sense, the complete response to neoadjuvant immunotherapy on melanoma might actually be a precursor, a surrogate endpoint for relapse-free and overall survival in melanoma. Studies have then continued on with the combination of IPI-NIVO, trying to reduce the toxicity, so going with low-dose IPI at 1 milligram per kilogram and Nivo at 3 milligrams per kilogram. And also, one of the latest developments has been the PRADO study, in which patients after their neoadjuvant course didn't have a full node dissection, but first had a resection of the marked index node to have the pathologist assess the response. And if they had a complete response, then no further dissection was done in those cases. 60 out of 100 patients had such a good response and did not have a complete node dissection afterwards. We're still awaiting the long-term results of this study to see if there isn't an increased risk of relapse in these studies. So that is a brief summary of what has happened. So this was also summarized at the EADO meeting just recently. And now we're very much looking forward to having the NADINA trial, which is a phase 3 trial comparing neoadjuvant IPI-NIVO to adjuvant immunotherapy in melanoma patients. And hopefully that trial will get started by early 2021.